Hello, everyone, and welcome to our module on spinal cord syndromes. Let's start by talking about poliovirus. So, poliovirus is a single-stranded RNA virus that can be prevented by vaccination. Polio infection in the modern era is very rare, and that's because of vaccines. It's transmitted in a fecal-oral fashion, so people who are infected can shed the virus in the stool, and then it can gain access through the oropharynx. Once this happens, it replicates in lymphoid tissue, usually in the oropharynx and small intestine, and this will cause a febrile illness. And sometimes this is all polio infection causes, but in a subset of people, polio can spread to the central nervous system, including the spinal cord. What it does in the spinal cord is it infects and destroys anterior horn cells. Those are the cells that supply axons that innervate our muscles. So when they're damaged by poliovirus, this leads to lower motor neuron type lesions, meaning a flaccid paralysis. So the term for poliovirus infection that has spread to the spinal cord is paralytic poliomyelitis. This is a picture of someone who had this condition years ago. This is very uncommon in the modern era. About 100 years ago or so, many children would get this infection. They would get a febrile illness, and then several days or weeks later, they would develop lower extremity weakness from the infection. So the way this presents is days after the febrile illness begins, usually patients develop meningitis symptoms. This is because of inflammation around the spinal cord. So they can have symptoms like fever and headache. They can also have symptoms of meningismus, which basically means neck stiffness. If you do a spinal tap, you will see the expected findings in a viral meningitis. So viral infections are fought off by T cells, so you will see a lymphocytic pleocytosis, which means an elevated white blood cell count in the CSF, mostly made up of T lymphocytes. You can also see increased levels of CSF protein. Around this time, patients can also begin to develop what's known as asymmetric weakness. So poliovirus is famous for having patchy involvement of the spinal cord. So first of all, the legs are more commonly involved in the arms, and affected people often have one leg that's affected and another that's not. I've had a few patients over the years who were from the era before the polio vaccine existed, and they had polio, and some of them had lingering weakness of one leg but not the other, and that's because of the asymmetric weakness. On clinical exam, you'll see flaccid muscle tone and other findings that you would expect with a lower motor neuron lesion. Potentially, it can progress to involve the respiratory muscles, and respiratory failure can occur, and that's how people die from polio infection. Importantly, though, because the key part of the spinal cord that's involved are the anterior horn cells, where you have motor neurons, you usually do not see any sensory symptoms. Okay, next let's talk about spinal muscle atrophy type 1, also known as Wernicke-Hoffmann disease. This is a clinical disorder that looks just like polio, except it's a congenital condition. It's not caused by an infectious disease. So it's going to present in a newborn infant without a preceding febrile illness. So Wernicke-Hoffmann disease is a congenital degeneration of the anterior horn cells of the spinal cord. It's going to present in a newborn or an infant with diffuse muscle atrophy and other lower motor neuron signs. And for all these disorders we're going to talk about in this video, what you want to get straight in your head is whether they present with lower motor neuron signs, upper motor neuron signs, or both. So the way this is going to present is in a newborn with hypotonia and weakness. A classic finding is tongue fasciculations in a newborn baby, and this is because of lower motor neuron lesions involving the nerves that innervate the tongue. Often the baby will be described as floppy, and as I said, you can see similar lesions to what you see in polio. That's because both conditions involve the anterior horn cells of the spinal cord. Wernicke-Hoffmann disease is an autosomal recessive condition, so both parents have to be carriers of an abnormal gene. And the gene that's mutated in this condition is called SMN1. That stands for survival motor neuron protein 1. And when this gene is mutated, this leads to defective SNRP assembly. So let's talk about what a SNRP is. A SNRP is a small nucleotide ribonucleoprotein. And what SNRPs do is they splice pre-mRNA into functional mRNA for protein transcription. I talk about this in a lot more detail in the cell biology section. But basically, when you have a mutation of this SMN1 gene, you cannot properly form mRNA, and that's going to lead to lower motor neuron apoptosis. Babies born with this condition die within a few months if they're untreated, but there is gene therapy that's available. Basically, there are new techniques to try and replace the defective gene and develop functioning SNRPs in the anterior horn cells of children affected by this condition. And then in case you're wondering, the other types of spinal muscle atrophy are types 2 through 4. They also lead to lower motor neuron loss. Basically, they vary by the age of onset and the severity. I don't think you have to know much about these conditions for your board exams. The classic example of spinal muscle atrophy is type 1 Wernicke-Hoffmann disease. Okay, moving on. Next, let's talk about amyotrophic lateral sclerosis. This is also known as Lou Gehrig disease. And if you don't know who Lou Gehrig was, he was a famous baseball player in the 1940s, and he had an exceptional batting average that began to drop off because of muscular weakness related to this condition, and that's why it's called Lou Gehrig disease. He eventually had to retire from baseball and then died. He gave a very famous speech when he retired. Search it up on YouTube. You can watch it. So in ALS, what happens is there's idiopathic degeneration of neurons, and as a result, upper and lower motor neurons are damaged and lost. This means that the clinical features involve both upper motor neuron symptoms and lower motor neuron symptoms. The upper motor neuron symptoms come from involvement of the corticospinal tract and the corticobulbar tract. These tracts provide motor innervation to the muscles of the head and neck and also the arms and legs. So patients can present with all the upper motor neuron features that I talk about in other videos, things like muscle spasticity and exaggerated reflexes. But you can also see lower motor neuron symptoms. These reflect involvement of spinal cord and brainstem neurons. So patients can also have wasting of muscles and fasciculations of muscles and also hyporeflexia. This is purely a motor condition, so there are no sensory symptoms and there are no bowel or bladder symptoms either. It usually involves the head and neck muscles and the muscles of the arms and legs. ALS is most common in people who are 40 to 70 years of age, and it's going to develop slowly. Remember, Lou Gehrig was able to keep playing baseball with this condition. So in a board question, if somebody had symptoms that began suddenly a few days ago, that's not ALS. It's going to present with slow development over the course of months. Involvement of the spinal cord nerves is going to lead to leg and arm weakness. Involvement of the cranial nerves is going to lead to things like difficulty swallowing, that's dysphagia, difficulty speaking, that's dysarthria. You can also see atrophy of the tongue. Usually this is fatal in 3 to 5 years. A common cause of death is aspiration pneumonia. So in general, patients can have weakness of the respiratory muscles, and then if they aspirate contents from the mouth because of dysphagia, that can lead to pneumonia, and this can be a cause of death. There's one treatment available. It's not very effective, but it does have some benefit. It's called riluzole. Basically, the idea behind riluzole and what you want to remember about this drug is that in ALS, there's excess glutamate activity in neurons, and this can lead to cell death. So riluzole, through a couple of mechanisms, decreases glutamate-related toxicity, and that's probably the most important thing to know about this drug. About 5 to 10% of cases are familial, meaning they're related to gene mutations that run in families. The most common cause is a gene mutation called C9orf72. Good luck remembering that. This is a gene mutation related to repeat expansions, meaning pieces of the gene that are normally present a few times end up getting expanded, so they're present many, many more times than normal. I talk about these disorders in the genetics section. So normally this gene has about 30 expansions of a certain segment, but in ALS cases, it can get to be over 1,000. The second most common cause, though, and the one that's most famous that you should definitely know, is SOD1 mutations. This was the first gene mutation described associated with ALS. So these mutations involve a gene for an enzyme called superoxide dismutase 1. And as I said, this was the first genetic form of the disease identified. This gene codes for an enzyme called a copper-zinc superoxide dismutase enzyme, which basically processes superoxide radicals, which are oxygen molecules with extra electrons. And so if you're deficient in this enzyme, what happens is these superoxide radicals persist inside of neurons and you get high reactive oxygen species. And these are dangerous and they lead to cell death. And this is the mechanism by which cells can die in ALS in patients who have this type of gene mutation. So you want to get good at recognizing the classic presentation of ALS. So the patient is almost always going to be 40 to 60 years old. About 50 years old is the typical age range. And the patient will present, as I said before, with slowly progressive weakness. Usually it will develop over months to years. It will usually involve the arms and legs. There can also be things like dysphagia to solids and liquids. Some of the muscles will be described as flaccid. These are muscles that have lower motor neuron lesions associated with them. And some will be spastic. These muscles have upper motor neuron lesions associated with them. And then finally, there should be no sensory symptoms. And this is a picture of a man with ALS here. He has to wear a neck brace to keep his head up because his muscles have become weak. Okay, moving on. Next, let's talk about an anterior spinal artery occlusion. So this refers to occlusion of the anterior spinal artery, which supplies the anterior 2/3 of the spinal cord. Everything shown in red in this image on the screen. We'll talk more about this in a second. The posterior spinal cord, where the posterior columns are, is supplied by the posterior spinal artery, so it's not affected in this condition. The anterior spinal artery is a branch of the vertebral artery, but this is not the most important thing to know about this vessel. The most important thing to know about this vessel is its relationship with the artery of Adamkowitz. Strange name, I know, but it's high yield to remember this for your board exams. So the artery of Adamkowitz is a radicular artery. This is a vessel that's near a spinal nerve root. That's why it's called a radicular artery. These vessels arise from the aorta between T8 and L1, and when they're damaged, they will lead to ischemia at one spinal cord segment. The other spinal cord segments will be protected by blood from other radicular arteries. So to understand this, let's imagine this is the anterior spinal artery. So it's a branch of the vertebral artery. That's what initially supplies it. But the vertebral artery doesn't give it enough blood to go all the way down to the bottom of the spinal cord. So it has these little branches that come in, giving blood from the aorta. These are called radicular arteries. And the one that's most commonly involved in anterior spinal artery occlusions is the artery of Adamkowitz. And so when you get one of these vessels, like the artery of Adamkowitz, that is damaged, that's going to lead to a segment of the spinal cord that has ischemia and has a characteristic pattern of ischemia associated with this condition. So the classic cause of an anterior spinal artery occlusion is actually not a thrombosis like in other stroke disorders. It's an aortic dissection or someone who had surgery for repair of an aortic aneurysm. These things can damage one of these radicular arteries like the artery of Adamkowitz, and that can lead to this spinal cord problem. You can also see it in patients who have diffuse hypotension, and it can sometimes happen from thrombosis like other strokes, but this is not the most common mechanism. So let's talk about the clinical features you would see in someone who has an anterior spinal artery occlusion. So basically, everything shown in red in this diagram is going to have ischemic damage. The only thing that's going to be spared is the posterior or dorsal columns. They get their blood supply from the posterior spinal artery. So vibration and proprioception will remain intact. But outside of this, you will see bilateral weakness or paralysis below the level of the lesion. So let's imagine that this is the spinal cord right here, and we've got one of these radicular vessels coming in, and it has damage, and so we get ischemia to a section like this right here. Well, what's going to happen is the corticospinal tract fibers running through this section are going to be lost. As a result, you're going to get weakness below the level of the lesion on both sides of the body because both corticospinal tracts on both sides are going to be damaged. So that's what you see, bilateral paralysis below the level of the lesion. Now, here's a tricky thing about this condition that you just have to be aware of. Initially, the paralysis will show lower motor neuron signs. This is a condition called spinal shock that happens when you initially deprive a region of the spinal cord of blood flow. You will get lower motor neuron damage in all the lower motor neurons at the level of the lesion and below. But this is only temporary. This is a shock thing that's going to resolve. A few weeks or so later, these are going to go away, and you're going to have upper motor neuron signs from damage to the corticospinal tract, just like I showed you in my little drawing. You may see lower motor neuron signs remain at the level of the infarct, but below that there will be upper motor neuron signs. So you'll read in some sources that anterior spinal artery occlusion caused lower motor neuron or upper motor neuron signs, and this can be confusing, and it's because of this quirk right here. Initially, it's lower motor neuron signs from spinal shock. Later, it's upper motor neuron signs. And then in terms of sensory information, you have the spinothalamic tracts running out here in this region of the spinal cord that's damaged. So you're going to have bilateral pain and temperature loss below the level of the lesion. As I said before, only vibration and proprioception will remain intact. Okay, moving on. Next, let's talk about tabes dorsalis. This refers to spinal cord involvement in neurosyphilis, which is a form of tertiary syphilis infection. Syphilis is a sexually transmitted disease. I talk about it in detail in videos in the infectious disease section. Here I'm going to focus mostly on the spinal cord features of tertiary syphilis, and that's tabes dorsalis. So in tabes dorsalis, what happens is you get degeneration of the posterior columns found in this region of the spinal cord. These are also called the dorsal columns. They're made up of two nerve bundles. One's called the fasciculus gracilis, the other's called the fasciculus cuneatus, and I talk about this in detail in the video on the spinal cord. As a result of losing this region of the spinal cord, patients will lose their sensation to vibration, fine touch, and proprioception. And this is all caused by demyelination and loss of axons related to syphilis infection. What they're going to present with clinically is what's called a sensory ataxia. This means a loss of balance and ataxia related to inability to sense the world around us through proprioception. So they will have an unstable, classically wide-based gait. They make their gait wide because they don't have proprioception, so they can't feel the world and they don't want to fall over, so they widen their gait. They can have difficulty walking, especially in the dark, because in the dark you can't see and you really need your proprioception to walk. There will be a positive Romberg sign, and then if this goes on chronically, patients can develop what are known as Charcot joints. This basically means degeneration of the knees and hips, and it's something that happens to anyone who has long-standing loss of proprioception. They won't be able to control their muscles in their legs from loss of balance, and that will lead to uneven distribution of forces on the knees and hips, and this can lead to a breakdown in joints. Tabes dorsalis is incredibly rare in the modern era, but 100 years ago, before antibiotics, many people had chronic syphilis infections and they would develop this disorder. And one of the signs would be a wide-based gait. Another sign would be that their joints in their knees and hips would break down. Now, besides the posterior columns being damaged in tabes dorsalis, you also get degeneration of the dorsal roots and dorsal root ganglions. So in the spinal cord, these are the roots of the spinal cord, and these back roots here, which are called the dorsal roots, have ganglions, which are a collection of cell bodies. Those neurons are sending axons out to pick up sensory information and sending axons in to send sensory information to the spinal cord, and they get damaged in tabes dorsalis. As a result, you lose sensory input to the spinal cord. This means that afferent limbs of reflex arcs are going to be lost. So tabes dorsalis often affects the legs, and these patients will have hypo or areflexia because of damage to these dorsal roots. This mostly affects the legs. The big reflexes that are affected are the patellar and Achilles reflex. You also tend to get shooting pains down the legs because of sensory irritation of the dorsal roots. And in case you're wondering, the dorsal roots also contain nerve fibers and neurons that pick up things like pain and temperature sensation, but those usually aren't affected in tabes dorsalis. The main clinical consequence of the dorsal roots being infected is that you lose the afferent limb of reflex arcs, and also this contributes to the loss of the sensory information in the posterior columns. Importantly, the anterior horn motor fibers are not affected, so strength is normal. And then another classic finding is the Argyll-Robertson pupil. I talk about this in the ophthalmology section, but this refers to a pupillary finding you can see in patients who have neurosyphilis. So the pupils will be small and irregular, and they react to accommodation, but not to light. And if you search this up on YouTube, there's a couple of great examples of this in a video, so you know what an Argyll-Robertson pupil looks like. It's a classic finding on pupillary exam in patients who have neurosyphilis. So the classic case of tabes dorsalis to be aware of is going to be a patient who, first of all, has other sexually transmitted diseases, just like syphilis. They will have difficulty walking, and that's because of the sensory ataxia. Their strength in the legs and arms will be entirely normal. They'll have a positive Romberg test. That's what's depicted in the top two panels of this picture on the screen here. They'll have a wide-based gait. They'll complain of fleeting, recurrent shooting pains. When you test their lower extremities, they'll have an absent or hyporeflective ankle and knee reflexes. And then an eye exam, they may have Argyll-Robertson pupils. Okay, next let's talk about syringomyelia. So syringomyelia is a condition where a syrinx forms in the spinal canal in the center of the spinal cord. So a syrinx is a tube filled with fluid. So if you look at this little drawing on the screen here, the spinal canal is found in the center of the spinal cord. And so if a cavity forms there, that's called a syrinx, and it fills with fluid, basically you get destruction of this region that I'm circling with my pen here. The main thing that that's going to do is damage spinothalamic tract fibers. So if you've watched the video on the spinal cord, you know that fibers carrying pain and temperature sensation cross the spinal cord like this from one side to the other. They go right through this region in the center that's affected by the syrinx in syringomyelia, and therefore they get damaged. The spinothalamic tract fibers are the first fibers involved, and that's because they cross at the center of the cord. And as a result of this, what you get is bilateral loss of pain and temperature sensation at the level of the lesion. And usually these lesions occur at C8 to T1, that's sort of the upper thorax. So that leads to a so-called cape-like distribution of pain and temperature loss. So it looks like what's shown in this slide right here. So if you had a syrinx sort of at this level in the spinal cord, all these fibers that are bringing pain and temperature sensation up the arm and crossing, those all get damaged. And you get this cape-like distribution of loss of pain and temperature sensation. Sometimes the loss of pain sensation presents as burns or cuts that are not being felt, and that's sometimes how patients with this condition first come to medical attention, because syringomyelia develops slowly over a long period of time, and so one of the first signs could be that someone cuts themselves or burns themselves on the hands or arms, which are usually affected, but they don't feel the pain. Now, even though syringomyelia begins with a syrinx or a cavity that affects the spinothalamic tract fibers, that cavity can grow in size over time, and eventually it can damage the anterior horn cells. So this can lead to muscle weakness with a lower motor neuron type pattern. Also remember that in the region of C8 to T1, where syringomyelia occurs, that's also where you find lateral horn cells of the sympathetic nervous system. So if the syrinx or cavity expands and damages these cells, you'll lose sympathetic innervation to the face, and that will lead to Horner syndrome, which I talk about in great detail in other videos, but it presents with signs like ptosis of the eyelid and dilation of the pupil. And then you should know that these cavities forming in the spine can affect the curvature of the spine, leading to abnormal curvature. That's called kyphoscoliosis. And then importantly, the posterior column is almost always normal, so proprioception and vibration sensation should be intact. So as I said before, usually these cavities develop slowly over years, and this is an important clue in a question. If they describe something that came on acutely over the last few days or hours, then they're talking about polio or anterior spinal artery occlusion or something like that. They talk about something that develops slowly over years, then they could be talking about syringomyelia. The most common cause is a Chiari-1 malformation. This is a congenital malformation involving the cerebellum, and I talk about it in detail in other videos, but it often co-occurs with a syrinx in the spinal cord. These are also common post-traumatically, so someone who has an injury, years after the injury, can develop one of these cavities that can fill up with fluid and start to grow. And then they can also occur in other settings, like if someone's had meningitis, that can open up a syrinx, which can grow over time. This is post-infectious. You can also see a post-inflammatory syrinx develop after someone who had transverse myelitis, for example, associated with multiple sclerosis. There are also neoplastic syrinxes that form. This is when tumors obstruct CSF flow, and that can lead to a cavity. The diagnosis is usually by MRI. This is a picture of a syrinx shown here. This is it, this white area in the middle of the spinal cord. These are fairly easy to identify by MRI, even as an early med student, so you should get an idea of what they look like in case you see one in a board question. Okay, our next spinal cord disorder is subacute combined degeneration. This refers to spinal cord demyelination associated with vitamin B12 deficiency. You need vitamin B12 to myelinate axons, so if you're deficient, you can develop this problem in the spinal cord. You also need vitamin B12 to develop red cells, so if you're deficient, you can become anemic, and I talk about that in videos in the hematology section. The name of this disorder tells you everything you need to know about it, so it's called subacute because it develops slowly over weeks or months, not acutely over hours or days, and not chronically over years. And then it's called combined because it affects the combined posterior columns and also the lateral corticospinal tract. If you recall, both of these tracts have nerve fibers that are large and myelinated. I talk about this in the video on cells of the nervous system. And so because these two tracts have fibers that are large and myelinated, they're the ones that get affected in a B12 deficiency when you can't make myelin. So what are the clinical features of the spinal cord damage that occurs in this condition? Well, first of all, the posterior column is affected. So this will lead to loss of vibration and proprioception sensation. Patients will have a positive Romberg sign. They can have a sensory ataxia, which means it's hard for them to see, especially in the dark, and they often develop a wide-based gait. And then there's damage to the lateral corticospinal tract. This leads to weakness with upper motor neuron features, things like hyperreflexia and clonus and a positive Babinski sign. Often there are associated neuropsychiatric symptoms. This has to do with loss of myelination of central nervous system axons in the brain. So besides the features we talked about in the last slide related to spinal cord problems, patients can have memory impairment, irritability, depression, and dementia. And because of these features here, in any person who presents with new onset confusion or dementia, usually a B12 level is checked because B12 deficiency could cause some of these symptoms. And then remember what I said, it's a subacute course. So in a board question, it's going to be described as developing slowly over weeks to months, not days like you would see in polio or in an anterior spinal artery occlusion, and not years like you might see in ALS or tabes dorsalis. Importantly, you can see the neurologic symptoms before the anemia, so just because the patient has a normal hemoglobin or red cell count, it doesn't rule out this condition. And then the diagnosis is usually made by identifying a low serum B12 level, but you can do an MRI and you will find abnormal posterior and lateral cord features when you look at the MRI images of the spinal cord. Okay, next let's talk about Brown-Séquard syndrome. This refers to hemisection of the spinal cord, which means damage to half of the spinal cord. This usually occurs as a result of trauma to the spinal cord or sometimes tumor invasion of the spinal cord. It leads to a spinal cord lesion that looks like what I've shown here, where exactly half of the spinal cord, everything shown in red here, is going to be damaged. So what this is going to do is it's going to damage a bunch of tracts which are traveling down and up the spinal cord, but it's also going to damage cell bodies at the level of the lesion. So you're going to have different clinical features depending upon whether you're talking about the level of the lesion or below the level of the lesion. So let's talk about the level of the lesion first. You're going to lose all those neurons coming into the spinal cord carrying sensory information. They can't transmit that sensory information to this half of the spinal cord. So you're going to lose all sensation at the level of the lesion. You're also going to lose all the anterior horn cells right here at the level of the lesion. That's going to lead to lower motor neuron weakness. Below the level of the lesion, you're going to have damage to the cortical spinal tracts, which are running downward through the area that's affected. So you will have ipsilateral upper motor neuron type weakness. This refers to weakness associated with spasticity and hyperreflexia. You're also going to lose the posterior columns on the affected side, so you're going to have ipsilateral or same side as the lesion loss of proprioception and vibration. And then remember, the spinothalamic tract fibers running up and down the spinal cord carry information from the opposite side of the body. So below the level of the lesion, you will have loss of pain, temperature, and crude touch that's contralateral to the side of the lesion. So the way most people remember this is by remembering this diagram, which I've shown right here. So at the level of the lesion, on the side of the lesion, you lose all sensation. Below the level of the lesion, you have impairment of all these things described down here. First of all, you lose proprioception and vibration. This is from loss of the posterior columns. You're also going to have weakness down here, but it's going to be with upper motor neuron type features. On the opposite side of the body, this is where you've lost the spinothalamic tract. So this is where you have impaired pain and temperature sensation. So I've summarized all these things over here on this slide. First of all, the side with motor weakness, that's the side with the lesion. This is the easy way to figure this out in a board question. At the specific level of the lesion, you will have lower motor neuron signs from damage to the anterior horn cells, and you will have loss of all sensation. This is everything: pain, temperature, proprioception, vibration. And then just an aside, but if the lesion is up here above T1, you can also lose those lateral horn cells, which are part of the sympathetic nervous system, and that can lead to Horner syndrome with pupillary diameter changes and eyelid droop and all the things I talk about in other videos. Below the lesion on the same side is everything shown in dark blue right here. This is where you're going to have weakness with upper motor neuron signs from loss of the corticospinal tract. You're also going to have loss of the posterior columns, so there will be loss of vibration and proprioception. And then below the lesion in light blue here, that's the opposite side from the lesion. This is where you have loss of pain and temperature sensation from the spinothalamic tract. So remember, board questions about this condition can be confusing. The weak side is always the side with the lesion, and the loss of pain and temperature sensation always occurs on the opposite side. Okay, next let's talk about the cauda equina syndrome. And as the name implies, this refers to compression of the cauda equina. So let's talk about what the cauda equina is. And to understand that, let's look at this drawing on the slide here. So this is the spinal cord, but note that it ends right here at about the L2 level. And this region where it ends is called the conus medullaris. But there are all these nerve fibers that continue to run inferiorly and give off nerve roots in the sacral area. And all these nerve fibers are called the cauda equina. This is a Latin word that means horse's tail, and these fibers that are long were thought to look like the tail of a horse. And the cauda equina gives off nerve roots that come off the spinal cord, especially at the sacral level, which are motor to the lower extremity. They're also sensory to the lower extremity. They also innervate the pelvic floor and the anal sphincter and areas like that. So you can get compression of these fibers for a couple of reasons. One thing that can cause this is a massive intervertebral disc rupture. You can also see this in patients who have trauma and fractures of the spinal cord. You can also see it sometimes from patients who have large tumors growing in this region. So when a patient gets the cauda equina syndrome, first of all, they usually present with severe low back pain. This just indicates the region where there's inflammation at the level of the lesion. Second classic finding is saddle anesthesia. This refers to numbness and tingling in the perineum, the buttocks, and the inner thighs. It's this whole region shown right here, including the inner thighs. That's called saddle anesthesia. It's the regions of skin that would sit over a saddle. Next classic feature is bowel or bladder dysfunction. So patients can have urinary retention. They can have overflow incontinence. I talk about these problems in other videos. They can have constipation or fecal incontinence. And then in clinical testing, you can identify loss of the anocutaneous reflex, which I describe in other videos. And so, for example, in the trauma bay, when patients have had a major trauma, often the anocutaneous reflex is tested. And the idea here is you're looking for evidence of the cauda equina syndrome and damage to those spinal cord nerve fibers if that were absent. Then beyond this, sexual dysfunction, especially in men, is very common, like erectile dysfunction. That's because of damage to the nerves to the penis in the cauda equina. Other features you can see are lower extremity weakness. This can be bilateral or asymmetric, depending on the type of cauda equina syndrome. But very importantly, especially for step 1, the weakness is going to have lower motor neuron signs because all of those nerve fibers running in the cauda equina are lower motor neurons. Their cell bodies are back in the spinal cord before it ended at the L2 level, and these are long nerve fibers. So you're going to see things like flaccid paralysis, hyporeflexia. You can see absence of the ankle jerk reflex because that's an S1 nerve root type of reflex. All these things are related to lower motor neuron problems from cauda equina syndrome. And then sort of related to the cauda equina syndrome is the conus medullaris syndrome. This refers to injury of the conus medullaris, which, as we just talked about, is the terminal end of the spinal cord, usually occurs around the L1 to L2 level. This is going to present with similar features to the cauda equina syndrome, except you can have some upper motor neuron signs. So as we've already discussed, in the cauda equina, those are all lower motor neuron fibers, but in the conus medullaris, there are some upper motor neuron fibers, and they can be damaged in a conus medullaris syndrome. So as a result, you can get all the clinical features we talked about for the cauda equina syndrome, but you may see some spasticity or hyperreflexia or Babinski signs, and that's because of damage to these upper motor neuron fibers. The other features will be similar, things like saddle anesthesia, sexual dysfunction. Once again, the key distinction here is the upper and lower motor neuron weakness that is present. And that concludes our module on spinal cord disorders.